All right. So hi everyone. My name is Abdi. I'm co-president of Cardiology Society this year. I'm just going to introduce today's event. So today is going to be a revision session on murmurs and infective endocarditis. And the session is going to be run by Dr. Mohamed Kira, who is a cardiology registrar here in Wessex, and he is a former cardiology teaching fellow at King's. So he used to teach there as well. So hopefully this will be a really good session. We had the first revision session last week with Dr. Alex Bates, and it was an ECG session. And just a reminder that we've got the next session of those coming up. So the first session was last Tuesday, and that was on sort of basics of ECG and grounding in ECG kind of first principles. And then we're going to be doing acute coronary syndrome next week on Tuesday, 4 p.m. So just now seeing if Mohamed Kira is here in the call with us. I think he's here. Mohamed, are you there?
Yes, hello. Hi, good evening.
Hi, good evening. So hopefully that introduction was good.
Thank you very much for the kind introduction.
And yes. Would you like to share any slides with us today, or?
Yeah, definitely. I'm about to start the sharing. So welcome everyone to the meeting today. It's an honor to be there with you guys for the first. Actually, my first teaching session here at Southampton. So like my kind colleague has just introduced, I'm a former teaching fellow yet. I was at St George's University, London, so not King's, just to correct. And then
apologies.
And I just moved to Southampton about a month ago, and it's a pleasure to start with you right away. And hopefully it will be an enjoyable lecture for you all. Can I start up by asking first, can you all see my slides? Yes?
Yes, I'm able to see them, yeah.
Okay, so if anybody has had a question throughout the lecture, just please feel free to raise up your hand just electronically, and then we can just start discuss or wait till the end for the questions part. As you should know, the lecture today will be split into two parts. The first part is discussing about the cardiac murmurs, and the second part will be a case study about a case of infective endocarditis, how to diagnose and how to manage. Just a quick revision. When initially I was asked to do a lecture about cardiac murmurs, I was a bit hesitant. It's one of the complex clinical skills, I have to say. And basically, we all do struggle at one point on how can we interpret cardiac murmurs and how can we identify valvular heart disease. We find it tricky, find it difficult sometimes, or at least challenging. Yeah, this is a practical skill, and trying to discuss it online is not helpful. Is not easy. Do not expect me to be playing out any murmurs. It's just kind of an algorithm that I have established over the years, and it helped me a lot to try to identify cardiac murmurs and help the medical students I used to work with into improving their auscultatory skills. So what are the intended learning outcomes of the first part is, number one, to try to identify what are the causes of cardiac murmurs. When we were speaking about valvular heart disease here, and how to use an algorithm in order for us to understand cardiac murmurs. So basically, what is a cardiac murmur? So there is a theoretical definition, definitely for everything. It's the unusual heart sound produced between the heartbeats, and it is related to the turbulence of the blood flow, and just non-foremost, it's the whoosh that we hear if we are listening to the heart sounds. One of the trickiest things that we are trying to do when we are medical students is we try to listen to as many murmurs as possible, hoping to collect as many sound memories, or yes, auditory memories of cardiac murmurs that we have listened to over the years, and hoping that by the exam time we'll be able to listen, compare, and then reach out a diagnosis of cardiac murmurs. Yeah, this is not a very helpful skill. because we tend to try to look at only one part of how to interpret a cardiac murmur, and we tend to forget the remaining clues which might help us to identify the cardiac murmur. So the aim of this part of the lecture is to try to understand how can I interpret a cardiac murmur, and then you can reference it later once you start going into the hospital, listen to patients with different cardiac murmurs, try to understand what is going on there, and then relate back to it. So how can I, the first step of recognizing a cardiac murmur, and this is usually a challenging part. The first step and the most important step of recognizing a cardiac murmur is to make sure that you can actually listen to the normal heart sounds, S1 and S2, without being able to exactly identify that I can, over this area, listen to S1 and S2. Then the next step should be if there is an associated murmur or not. Sometimes we just a bit stressed, maybe an exam, maybe it's a kind of a busy environment. We put our stethoscope and we can't hear anything. So we kind of challenge ourselves. Am I hearing correctly, or there is a problem and I can't hear the patient? And then we get confused and we start to make murmurs that is not existent. So number one, it is very important to make sure that I have placed my stethoscope into the right place. Number one is I need to identify what are the places that I should be listening at. And number two, because of the anatomical variations between one patient and to the other, some patients have a big habitus, some patients have a chest wall deformities, some patients have a COPD, and so on. So if you put your stethoscope on the chest of the patient and you cannot hear S1 and S2, it's impossible that you can identify a cardiac murmur. So the first and easiest step is listen first for an S1 and S2. If you can find S1 and S2, then ask yourself, can I hear a murmur or not? So what are the cardiac causes of cardiac murmur? Well, any turbulent blood flow across the heart might cause a murmur. And for this session, we will refer only to the valvular causes of cardiac murmur. And theoretically speaking, there are so many causes of cardiac murmur that can get very much confusing to us all. So what can we do to try to identify those different types and sources of cardiac murmur? Very confusing and sometimes very challenging. So how to approach the cardiac murmur interpretation? So the first thing that I need to check would be the timing. When is this murmur going to happen? Number two, where is the area of maximum intensity? Where can I hear this murmur the loudest? Number three would be the character of the murmur. What type of murmur is going on there? Number four is the propagation. Where does this murmur goes to? And lastly, any special maneuver that you're trying to do or special positions that you're going to place the patient in order to establish what is the cause of these cardiac murmurs. Trying to think about those 5 factors in any murmur that you're listening to, and then you will reach the diagnosis, or at least a very good probable differential diagnosis. And be aware that some murmurs are very challenging to anybody, including a cardiology consultant, while if you can identify the ED, the straightforward murmur, this is a very good achievement, and then definitely will be able to progress your skills further. So let's start up with the first thing, which is the timing of the cardiac murmur. As we should know that the murmur happens when the blood flows when it is not supposed to flow, or when it's not when it's not flowing in the correct manner. The cardiac cycle is composed of 2 parts: the systole, when the heart contracts, and the diastole, when the heart relaxes and fills up. During systole, the mitral and the tricuspid valve should be closed, and then the aortic and the pulmonary valve should be open. So any causes of a systolic murmur should be including a mitral or tricuspid regurg, pulmonary or aortic stenosis. While during diastole, the mitral and the tricuspid should be open, and the pulmonary and the aortic should be closed. So any cause of murmur during diastole would be either mitral stenosis or aortic regurg, and likewise on the right side. So how can I identify the difference between systole and diastole? And usually it is tricky. Some people try to feel the pulse. Some people try to identify in relation to the heart sounds. And I would say to the latter, it is challenging, yet you can see some of the cardiology regs or cardiology consultants who actually do not feel the pulse while they are listening to the heart sounds. But it is very challenging, especially when you're learning about medicine. Try to compare two variables depending on your hearing sense only is not going to help you. So do not depend on that to identify the timing of the murmur, but try to feel the pulse. And usually the best place to feel the pulse should be the carotid artery, because number one, you need an artery which is bigger, and definitely the carotid is bigger than the radial. And number two, you need as closest to the heart as possible, and definitely the carotid artery is closest to the heart in compared to the radial artery. In addition, that patients might have problems regarding his peripheral vascular disease, causing the radial artery not to be felt properly, and this can cause further confusion. I know that some of you are not confident enough to feel the carotid artery, but this is your time. If you are training now, you need to be aware about the importance of being able to feel the carotid pulse. This is the pulse that you will try to feel if you are having a cardiac arrest. This is the pulse upon which that you will stop a resuscitation process. If you feel yourself, I'm not that much confident about feeling the radial artery, then this is the time for you to try to work on those very essential skills. So a systolic murmur would be happening, so you'll be listening to the murmur while you are feeling the pulse, and the diastolic murmur would be the murmur that you can hear in between the pulses. And just by this simple maneuver, very easy, you'll be able to subcategorize your murmurs into systolic murmurs and diastolic murmurs. And for this sake, we'll start speaking up about the systolic murmurs, because they're the most important, the most common type of murmurs, and then we will speak about the diastolic murmurs. So the second step is, once you identify there is a murmur, so I've listened, I've had my stethoscope, I placed on the chest of the patient in the designated areas, and I've been able to assess the presence of first and second heart sounds. So I know that I'm in a correct place. I've established the presence of a murmur. I felt the carotid artery, and it is a systolic murmur. Then the next question is, where can you actually hear this murmur the loudest? So go around, start in the aortic area or the mitral area, whatever you prefer, and walk your way through. Can you hear the murmur everywhere, or you can actually hear it loudest in some special place? So if you can hear it as loudest over the apex, then it's most commonly to be mitral regurg. If it's over the aortic area, it's most likely to be aortic stenosis. Same for pulmonary or tricuspid areas, because this is a very important second step. Then number three, which is the thing that we usually tend to try to identify only irrespective of everything else, which is the character. And this is what we try to do when we tend to listen only to the cardiac heart sound. We try to memorize the character only of the murmur, and hopefully by doing that we will be able to establish a diagnosis, which is not much helpful because it can cause lots of confusion. So what are the characters of the systolic murmurs that we know? There are two types of systolic murmur. As we should know, there is a crescendo-decrescendo murmur, which is called the ejection systolic or a mid-systolic murmur, and there is a whole hollow systolic murmur. What is the difference? The mid-systolic murmur most commonly happen with aortic or pulmonary stenosis, during which time during systole, once the left ventricle is starting to contract, it will close down the mitral valve. Then the pressure needs to start building up in order for it to open up the aortic valve. It will take some time because now the valve is sclerotic, it's tight, so it will take a little bit of a time between the closure of the mitral valve and then the time needed to build up the pressure inside the left ventricle to be able to open the now tight aortic valve. Then it will not be able to open it up right away because it's a stenotic valve. So it will take it a little bit of a time for the pressure to keep building up in order for it to reach the peak, okay, which is the crescendo arm of the murmur. Then once the pressure inside the left ventricle reaches its peak, it will start gradually go down, and so the intensity of the murmur will keep going down till the point that the pressure inside the left ventricle is unable to keep the aortic valve open anymore. Then the aortic valve will close, the murmur will stop until the pressure actually drops and you hear the second heart sound before you go again for the diastolic period. And this is produces the crescendo murmur, which sounds something like that. The other type is the holosystolic murmur, which occurs in cases of mitral regurg or tricuspid regurg. As we should know that during diastole, the mitral valve is open to allow the blood to pass from the atrium to the ventricle. During systole, once the pressure inside the left ventricle starts rising up, this pressure should close down the mitral valve and allow the pressure to build up inside the left ventricle so that it can open up the aortic valve. In patients who is having a mitral regurgitation, these valves cannot close properly, and so instead of it closing to produce S1, it flaps open on the other side depending on the severity of the mitral regurg and causing a murmur to start right away. So the murmur starts right away in the beginning of the systole, and then it continues until in the end of the systole, where actually the mitral valve opens back again, and so it continues to open all the time. During systole, it produces this holosystolic or a pan-systolic murmur. Something sounds like that. Is that all right? So again, the steps that we followed is number one, listen to the normal heart sounds. If they are there, we are in the correct place. Number two, we use the carotid artery to time if we hear any type of murmurs. Number three, we looked around the areas where the area of maximum intensity. Of the area of the maximum intensity, you should be able to try to identify what kind of a character that you're listening to. So is it an ejection systolic or holosystolic murmur? Number four, where would be the propagation of the murmur? Where would this murmur travel to? So like we have said, we are speaking now about the systolic murmurs. So we are speaking about 4 valvular disease that can cause a systolic murmur, named number 1, mitral regurgitation. So as we are all aware, if we are listening to mitral regurgitation, we will try to look in the axilla to see if the murmur propagates there. And what happens is, because during systole, the blood returns from the left ventricle into the left atrium, which is in the back to the left. So the blood carries the murmur with it into the axilla. And so when you hear into the axilla, you can hear the whoosh, the sound of the systolic murmurs coming to your stethoscope, which confirms the diagnosis of mitral regurgitation. In patients with aortic stenosis, because again the blood is leaving the left ventricle and into the aorta, so it carries up the murmur with it into the aorta, the ascending aorta, and then later into the aortic arch and perhaps into the carotids. So if you listen on the carotid artery, then you should be able to identify if there is a propagated murmur, and it should be, in this case, if you hear a murmur of the aorta which goes into the carotid artery, then it's an aortic stenosis. We should be aware that patients with having severe aortic stenosis, they should be having a very loud murmur that could travel everywhere across the heart, but as well it will be loud over the carotid artery, and then I can say actually this is an aortic stenosis. Yet a mild to moderate degree of aortic stenosis might only be audible over the aorta only. Alongside with that, might tend to slightly go over the carotid artery, and then following up the algorithm, you should be well. Then the next thing would be about the tricuspid murmur. And the question is, where would this murmur propagate to? So the tricuspid valve is supposed to close during systole between the left ventricle and between the right ventricle and the right atrium. Patients who are having a tricuspid incompetence, the blood flows from the right ventricle to the right atrium. The right atrium is located about the center of the chest. And so the murmur theoretically should go to the center of the chest, but this is not an area that we can access to. That's why we will not be able to hear a propagation of the murmur, which is actually very helpful. So if you listen and you find a systolic murmur, a pansystolic murmur over the tricuspid area, the left parasternal border, that do not propagate anywhere, and this is the area of maximum intensity, you can very easily identify that this is a tricuspid regurgitation murmur. Sometimes goes to the pulmonary artery, which goes to the center of the neck, which you can or you cannot hear a propagation to it, yet you can easily identify by the area of maximum intensity that this is a murmur that is loudest over the pulmonary area. The last step would be the accentuation. How can you make the murmur louder? As we know, number one, about the mitral regurgitation, we tend to try to ask the patient to turn to the left side, and we tend to listen to the heart sounds. Very simply, you are depending on the gravity to bring up the heart closer to a stethoscope so that you can hear the murmur loudest, and this is how you can accentuate it. Patients with an aortic stenosis, while asking them to sit forward, you can bring up the aorta itself, the aortic valve, closer to your stethoscope, and you can actually listen to the aortic stenosis a bit loudest. The question is usually regarding the tricuspid valve. How can I make a tricuspid regurgitation murmur louder? And usually this is so some of you might think, okay, it is the inspiration, and this is correct. It is by asking the patient to take a deep breath in and hold it while you're listening to the heart sounds. When you ask the patient to take a deep breath in, you are actually increasing the negative intrathoracic pressure. And by increasing the negative intrathoracic pressure, you are allowing more venous return, and so the right atrium will be filled up more with blood, and so the right ventricle. And as we remember, as per the Starling law, the more the preload or the more the resting length, muscle length, the more stronger the force of contraction. And so more blood inside the right ventricle, more pressure inside the right ventricle, then more tricuspid regurgitation, then the murmur will be louder. And again, the same principle applies for patients with pulmonary stenosis. So again, the more the blood inside the right ventricle that is trying to go out of the right ventricle into the pulmonary artery through a stenotic valve, then the gradient will be higher, and then the murmur will be higher. Is that all right? So again, just to recap about the principles that we have said so far. The first step, if I want to identify a murmur, number one, I need to ask myself the first and the most important question. Can I hear normal heart sounds, yes or no? If the answer is yes, then you ask yourself the second question, can I hear a murmur, yes or no? If there is a murmur, then you start up by timing, again, as a carotid artery. Is it a systolic or a diastolic murmur? Number two, the area of maximum intensity. Number three, where can I hear the murmur the loudest? Where does this murmur propagate to? What is the character of this murmur? And how can I make this murmur louder? And so we have spoken about all the four types of the systolic murmurs. Regarding the diastolic murmurs, there are theoretically four causes of diastolic murmurs, including mitral stenosis, tricuspid stenosis, pulmonary regurg, and aortic regurg. Luckily, patients with tricuspid stenosis is very rare, and it counts itself more of a congenital anomaly. And so it is very, very rare that you will ever meet a patient with pulmonary stenosis in adulthood who has not had it already been managed. So you don't have to worry yourself about patients with tricuspid stenosis. Secondly would be a pulmonary regurg. Actually, pulmonary regurg is common to be found. Usually it tends to be mild pulmonary regurg, and usually it is very unlikely to be able to identify it. So very simply, you try to identify whether the patient is having mitral stenosis or aortic regurgitation. In the first type, the mitral regurgitation, the mitral stenosis, you will be able to listen to the murmur loudest over the apex of the heart. Because during the murmur itself, what's happening, the blood should be trying to flow from the atrium to the ventricle, so the murmur will not propagate to the axilla. Number 3, it is a diastolic murmur that starts right away because the pressure at the end of the systole, the pressure inside the left atrium is the highest, and then the murmurs. Sorry, this is the second type. Sorry, the murmur will start going, and then it will show a systolic accentuation when the left atrium starts to close down. Compared to the diastolic murmur of the aortic regurgitation, that instead of the aortic valve closing right away, just opens up the aortic valve, and so the blood starts dropping down from the aorta to the left ventricle. Left ventricle, then the murmur tries to muffle down. So it's an early diastolic murmur compared to a mid diastolic murmur with a pre-systolic accentuation. This is more of a theoretical explanation for you to be able to identify one murmur. Mitral stenosis should be able to hear it the maximum over the apex of the heart, does not propagate, while with aortic regurgitation, you should be able to hear it over the aortic area, and it should radiate over the tricuspid area because this is the blood flowing from the aorta down to the LVOT tract. And this is how you will be able to identify between both types of diastolic murmurs. Just a few tips and tricks before we finish the first part about the murmurs and how to identify them, and we go for questions. The tip number 1. Try not to memorize cardiac murmurs, because just trying to memorize them as a whole will create a lot of confusion. You need to be able to identify, to think, what is the type of the sound I'm listening to? It is a difference between somebody who likes music and somebody who studied music. The person who studied music will listen, will be able to identify basically what is the instrument that is used, what is the rhythm that is followed up, what everything. You can even analyze the note and write it down. Compared to a person who just listens and enjoys the music, we are physicians. We try to at least what is going around the heart, try to interpret what we're listening to. Number 2, when you are trying to imagine yourself now in a very busy area and you're trying to make a phone call. You'll find it very, very tricky. You'll find yourself struggling to interpret what is going around you, or what is coming from the other side. While if you take a step away, sit down in a silent area, phone call, you find the conversation is very easy. Patients for whom we examine every day do not know what are we going to listen to. Are we going to listen to their chest, or are we going to listen to their heart? And over years, whenever a physician they see, they place the stethoscope on their chest and ask them to breathe in and out. So lots of time when patient sees that you place your stethoscope in their chest, they will intentionally increase the frequency of their breathing, thinking that they are helping you, even if you did not ask for them. And this can be very confusing for you, trying to identify what kind of murmur is going on there. So try very simply, ask the patients, breathe in, breathe out, and hold their breath while you're listening to the heart sounds. By doing that, number 1, you're asking the patient to hold their breath, so you will not be confused between the murmur sound and the sound of the breathing of the patient. Number 2, holding their breathing at the end of expiration will mean that their chest will be deflated
and then the air will not work against you. It will not be a kind of a buffering layer, but you will be emptying up the chest. And then you will be able to identify the left-sided murmur very easily. And then when you go to the maneuver side, if you think that you're having tricuspid regurg or pulmonary stenosis, then you can ask your patient to take a breath in, and then you can actually hear the murmur. So this is the second tip. Try to ask the patient to hold their breath while you're listening to their chest. The third tip would be when you are doing your examination, at the exam, the final exam, you're trying to listen to the heart murmurs, try to make up your diagnosis before leaving the patient. What happens is, when we are stressed, we try to listen to things, we will not manage to interpret them, we just say to ourselves, okay, it's good, I heard something, and then I'll think about it when I leave the patient. Then you leave the patient, and then you start to making up a diagnosis. At this point, your mind will play all the tricks on you. It will convince you whether this is a systolic or a diastolic murmur, whether it's a crescendo, decrescendo, or a holosystolic murmur, and you can listen to all the sounds playing up in your mind, especially like we have said before, if you only collected sounds, you did not learn how to interpret them. So try to confirm your diagnosis. Is really systolic or is it diastolic murmur, and where is the area of maximum intensity, and so on and so on. It's very important to be able to identify your timing, because basically this will definitely change your differential diagnosis. It doesn't make any sense if you go to your exam and tell, well, I can hear a presence of a murmur and it's either mitral regurg or aortic regurg. Well, one of them is systolic and the other is diastolic. Doesn't make sense. It doesn't identify that you have actually married. But if you come up with a diagnosis that the patient is having mitral regurg versus aortic stenosis because I heard the presence of a systolic murmur, then you showed that you will be able to identify signs correctly. So it's very important to work on your timing. Never forget to feel the carotid when you're listening to patients. The last tip would be about the fact that it is equally difficult for us to say that there is no murmur when compared to actually saying there is a murmur. And usually we find this tricky question. When we hear patients, when we're looking for patients to examine, we only look for patients who does have murmurs, and we listen explicitly to those patients. While we are generally examining patients who is presenting with anything, even if we listen to the heart sound, we'll be listening quickly, we'll be listening without much attention, and then yes, it's just normal heart sound, and this is when we miss actual murmurs. So when you're trying to examine patients, try not to know what's going on with them. Try to listen to patients carefully, while even if they do not have murmurs, and then try to develop the habit of being able to say, well, actually, there is no murmur there. Okay, so those are the tips and tricks that I've collected over the time. And this is the end of the first part of the lecture. So anybody does have any question, please raise up your hand. Or alternatively, I believe you can share a message, although I have no access to that. But
you can write in the chat if you have a question as well, and I'll be able to read it out to Dr. Kira. So if you don't want to speak, you can just write it in the chat as well.
Okay, so meanwhile, and before we start the infective endocarditis case, I will suggest if we have a 5 minutes break, just refresh yourself, get something to drink, and then we will meet up at 7:40 to go through the case of infective endocarditis. Is that all right, guys? And then if you have any questions, just please feel free to text them meanwhile, and then we can answer them at the end of the session. Is that all right?
Perfect. Yes, we'll see everyone back at 7:40.
Yeah, hi everyone. I hope you managed to have something quickly to drink or maybe stretch your legs or so, and should be able to start. Is that all right?
Yeah, I think you're all good to go ahead and start.
Perfect. Thank you very much, Emily. And I would ask your help for the next part of the session. So this part, we will try to engage people as much as possible. So I have no access to check the messages. So if you'll be able to check the messages and help with answers to some of the questions, would be all right.
Yeah, no problem. And guys, if you could all get involved, that'd be really good and keep it interactive.
Perfect. Okay. Yes.
I don't know if this is for everyone, but with the chat, it just says it's only available for team members at the moment. I don't know.
Okay. So hopefully you'll be able to unmute yourself yourself, and then everyone else that if you don't have access to the chat, maybe try and use the voice. I'm really sorry. I don't know if we can change that at this point.
That's fine. Thanks.
Cool.
Okay, perfect. Yeah. So basically, what is the intended learning outcomes of this part? Is just understanding what is the diagnosis, how we diagnose patients with infective endocarditis, and how can we manage cases of infective endocarditis. So for this case, we use a patient, Mr. LJ, and he's a 52 years old chap who's presented to the hospital maybe a few days ago with fever and shortness of breath. History presented complaint. Basically, his gentleman has been feeling unwell in himself over the last week, has been feeling tired, has been having some ongoing fevers over the last 3 days, yet he denies any coughing, any dysuria, or any nausea or vomiting. Taking his past medical history, there was nothing significant. He doesn't take any regular medication, does not have any drug allergy. He's a non-smoker with 10 to 15 units of alcohol per week. He works as an accountant and he lives with his partner. So anybody has any questions that you'd like to ask these patients about?
Is he using any drugs?
Perfect. This is a very good question. This is a patient who denies. No, he doesn't use any IV drugs at all. Perfect. Very good question. Any ideas? Anything else?
Any dental procedures in the past?
Perfect. This is a very good question. Any procedures or any operation that the patient had, then yes, he will tell you actually about 10 days ago, he had a problem regarding his tooth and he went to his dentist who had done kind of a filling to his tooth. He told him that it needs to be extracted. Yet the patient refused at the time, so have done him some temporary filling until he sorts himself out. Very good question. Any other questions at all?
Has he been unwell recently with a cold or anything like that? Not very long ago.
Okay, so very good question. So basically, he denies any other specific symptoms except for the shortness of breath, the fatigability that has happened over the last week, and he has noticed the fever over the last 3 days. It has been coming most of the time. Trying to take some paracetamol over the counter, thoughts to himself whether it's COVID or not. Shall I self-isolate and do nothing, or shall I get tested? He doesn't have any cough, and so he got a little bit hesitant to seek medical attention at first, but since his symptoms persisted, that's why he went to the hospital. Anything else?
Is there any family history?
Any family history. So basically, the patient denies any specific family history. But in cases of a patient who's presenting to you with fever, it's unlikely that there is any specific family history that will be, except for maybe some kind of a familial Mediterranean fever, but it will show episodes of fever long ago before the age of 52. Other than that, it's unlikely that there is anything specific, but very good question. Anything else? Any other thoughts?
Is he a recreational drug user?
Okay, very good question. I think we have answered that earlier, but yeah, he denied using any recreational drugs, any IV drug use specifically, or any other types of drugs, either sniffing or whatever.
Does he have any wounds, or has he had any tattoos done, or any breaks in his skin?
Perfect. So again, looking for any procedure that he had recently, and then again, this only for exception of the dental work that the patient had 1 week ago. Sorry, 10 days ago, he didn't have anything. So basically, I do actually appreciate all the tools that you are having. Yes, if I'm having a patient who is having with fever, I need to identify what is the cause for the fever of the patient. Go systematically. Don't worry about asking the patient that the patient does have any evidence of headaches, any rashes, any symptoms of meningism. Ask the patient about nausea and vomiting. Ask the patient about respiratory symptoms, cough, sputum. Ask the patient about gastrointestinal symptoms, UTI symptoms. So always go systematic in any patient coming with fever, even if there is a high suspicion, and then go as well for any procedure that the patient might have recently, any kind of surgery, especially dental work. Patient do not think that my teeth is fine, I'm all right. Why shall I have a fever related to that? And then he might be reluctant to mention it out unless you actually prompt the patient to. He will forget all about it. He had it 10 days ago. It's all sorted. His tooth is fine now. I have nothing to worry myself about. Perfect. Well done, guys. And then we went to examine the patient. The patient was able to lie flat in bed. The GVP was not raised. Chest was clear on examination. Listen to the heart sound. There was an S1 and S2, and there was a systolic, pan-systolic murmur over the apex. Just having discussed murmurs, what do you think about what is the likely cause of the murmur here? Pan-systolic or a holosystolic murmur over the apex of the heart. What do you think, guys?
Mitral regurg.
Perfect. Yes, I was thinking about mitral regurg, whether it's true or not. We'll wait and see. And then no evidence of peripheral edema. Checked his blood pressure was fine. His heart rate was regular, a bit tachycardic, corresponding to the fever of 38.2, and respiratory rate was 17. So the patient was in tachypnea. Anything else that you'd like to look for during your examination? So you've listened to the chest, you've listened to the heart, you've looked at the you look at the GVP, looked in there for legs for any presence of edema, check the vital signs. Anything specifically that you'd like to examine for in this case?
Would you look for nail changes? So, for example, splinter hemorrhages or skin changes at the hands?
Perfect. So you look for splinter hemorrhages, you look for osseous nodules or Genoa lesions. Why did you think about those? So despite the fact that we're actually discussing a case of infective endocarditis, we are sure that we know all the correct answers. But the trick is, if you're having a patient with a fever who is able to establish the presence of a murmur, then you need to ask yourself whether this murmur is the result of infective endocarditis, or this murmur is a predisposing cardiac condition that might lead to infective endocarditis. So that's why any patient that you do examine, especially if you're going for your exams, listen for the cardiovascular examination station. If you hear a murmur, then you need to tell the examiner whether there was any evidence of infective endocarditis or not, because it shows that you actually was being able to listen to find the murmur, and you're able to identify the importance of establishing the diagnosis of infective endocarditis in those patients. Is that right? Going to the next part. So basically, like we have said about looking also in your Genoa lesions to suspected infective endocarditis. Is that right? Yes. So basically, what are the criteria of diagnosis? When should I suspect infective endocarditis in this patient? Anybody has a clue? What are the criteria for diagnosing infective endocarditis? Any of them?
Positive blood cultures.
Positive blood culture. So basically, there is major criteria, there is minor criteria. Positive blood culture forms the first part of the major criteria. So you need a specific positive blood culture, so something that is typical for infective endocarditis, like strep viridans or Povis, Hasek group, or Staph aureus. And this is either two separate blood culture samples about 12 hours apart, or 3 samples from 3 sites that at least 1 hour apart, so you can establish the presence of septicemia. It's not a contaminated sample. Any other thoughts regarding criteria for infective endocarditis?
Fever.
Fever. Perfect. Is this a major or minor criteria?
I think that would be a minor one. I think, sorry, someone else was going to say an answer as well.
Okay.
Presence of a new murmur.
Perfect. So presence of a cardiac murmur. This is one other major criteria. So the presence of either worsening of an already established murmur. So you know that the patient does have a slight microcardiac murmur. Now it's severe murmurs, very loud, or a presence of a murmur that wasn't there before, or an echo evidence of an infective endocarditis. So this can replace that, and both of them can be part of a major criteria. Like we said about the fever, one of the minor criteria. What else? We have shown up another one is the predisposing cardiac conditions or IV drug use. This is again one of the minor criteria. Any other minor criteria that you know, guys?
If you have any splinter hemorrhages or Janeway lesions.
Perfect. So splinter hemorrhages, Janeway lesions. So we have said about the temperature. We have said about vascular phenomena like Janeway lesions or myocardial aneurysms or arterial emboli and so on. So anything else? The next would be an immunologic phenomenon, like I've said about the oscillatory reduced, and finally a blood culture that is not fulfilled the criteria to become a major criteria. At this point, it becomes a minor criteria. Then the next question would be, how many major or minor criteria that I need to be able to suspect infective endocarditis, and in which combinations? Any clue?
Is it 2 major or 1 major and 3 minor or so?
Absolutely correct. So either 1 major, either 2 major, 1 major and 3 minor, or the whole 5 minor criteria. At this point, you're having a high suspicion for infective endocarditis. Is that all right? So far we have examined this patient. Does the patient have any criteria that we haven't had so far? So the patient was having a fever, 1 minor criteria, and he doesn't have any predisposing cardiac condition, yet he's having a murmur that is not recorded before. The patient doesn't have any past medical history, and he might have splinter hemorrhages or ozone-induced Janeway lesions. So this patient does have about 2 minor and 1 major criteria. Is that all right so far?
Yep.
Yes, perfect. Okay, so the next step, we've done some bloods to the patient. He's in the emergency department or being admitted, and the blood has shown. Well, anybody would like to tell us what if there is any abnormality that you think in the blood? I know that I haven't played the normal values, but what do you think?
The CRP is definitely raised.
Perfect. So the CRP is 117, is definitely raised, and the white cell count is normally at 11. So what do you think? So between 4 and 11, the normal cell count. So the white cell count is high, the CRP is high. So again, consistent with the infection, we've done blood cultures, and the result for the blood cultures is negative. So what do you think should be the next step in this case? So we have this patient, fever, murmurs, maybe some evidence of query infective endocarditis, have some dental work about 10 days ago, have done some bloods showing some evidence of infection. What would you like to do now for this patient?
Maybe organize some imaging.
Perfect. What kind of imaging would you be looking after?
An echocardiogram.
Perfect. Anything else?
You might want to do a CT to look for an abdominal source of the infection.
Okay, so basically part of your examination would be guiding you where might be the possible source of infection. That's why we'll do an abdominal examination. If you find the abdomen soft and tender, it's unlikely that there is an abdominal source of examination unless the blood culture would show you that there is actually something, some kind of a weird bacteria that normally lives in the guts and now it's found its way to the heart. Then at this point you need to investigate the abdomen. But part of it may be excluding other causes. So again, doing a chest X-ray, maybe a typical pneumonia that is present there. Maybe you're doing a urine dip just to exclude UTI, but definitely try to arrange an echocardiogram for this patient. So this is the echo of the patient. As you can see, it's a bit tricky to interpret the echo images for medical students, definitely. But just to simplify things, when we're looking at the echo, we look at the heart and it's upside down, so the ventricles to the front, sorry, the ventricles are upward and the atrium are below. And then ventricle to the right and right ventricle to the left. So you can find there's a kind of a mass attached here to a valve between the left ventricle and the left atrium. So which valve is this one?
Mitral.
Mitral valve, perfect. And this valve is?
Tricuspid.
Tricuspid, perfect. Yes. So you have the tricuspid valve between the right ventricle and the right atrium, and the mitral between the left ventricle and the right ventricle. So actually we have seen a mass that is present there. So we have an echo findings, we have a fever, and we have some peripheral signs in the patient with clear infective endocarditis. So what would you like now to do to this patient? Any idea?
Start antibiotics.
Perfect. Yes. So do you have any specific antibiotics that would you consider in this case? Shall I aim gram positive? Shall I aim gram negative? Shall I aim any ropes?
Vancomycin.
Okay, and somebody else was trying to say something?
And Paragon benzyme penicillin if not an allergic.
Okay, so basically, very simply, I don't know what the organism that is going to be there. It can be anything. So the guidance say that we should give him something that is a bit broad, a spectrum antibiotics. It depends on the presentation of the patient, whether the background, whether it's likely to be a community acquired infection, meaning that the patient had the infective endocarditis not following a procedure that the patient has had. Okay, so he didn't have it. He had it on the native valve, or a patient who is having a prosthetic valve that has been done more than 12 months post surgery. A patient who is having an early infection, like had the valve replaced within 12 months, or likely that it is contamination from being in the hospital, underwent a procedure in the hospital and then developed infective endocarditis and likely to develop some kind of a nosocomial bugs. At this point, the antibiotic therapy will change. In our consideration, we're thinking that the patient might have dental work, it's not a surgery, and then the bug that is likely to be there is mostly related to the bug that is present in his oral cavity, and so we will go for the option, this number one, depending whether the patient have drug allergy or not. The patient doesn't have, so we will consider ampicillin plus flucloxacillin plus gentamicin. Does make sense?
Yeah.
Okay, fab. And then later on, the blood cultures came back showing ampicillin sensitive Staph aureus. Perfect. So what should we do now? Should we change the antibiotic therapy? The patient's fever is now subsiding. The patient is feeling generally well in himself. Would you like to continue the same antibiotic therapy, or would you consider changing now the antibiotic therapy?
Consider
Continue.
changing it.
Pardon?
Sorry, continue it.
Continue it, or so basically we have started now the patient on a broad spectrum of antibiotics. The patient is responding well, but we know the bug, and the bug is a Staph aureus that is sensitive to flucloxacillin. So why would I consider giving the patient lots of other antibiotics? So the guidance said this way: if you're having a native valve and if you have managed to identify the bug, in this case it's a methicillin susceptible Staph aureus, then there is no point of continuing of a broad spectrum antibiotic. Now you can reduce down to single agent, which is a flucloxacillin or oxacillin, for 4 to 6 days doses per day for about 4 to 6 weeks. Is that right? Okay, So now we've switched the antibiotics for the patient, and now we start the hemofloxacillin. The patient is staying in the hospital. If there is anything that while the patient is in the hospital, should I be looking at, like any special thing that I need to monitor while the patient is in the hospital?
Urine dip.
Why? Why would you like to do urine dip?
Autoimmune vascular.
Okay. So what are you thinking about? What would the urine dip show you?
Hematuria.
Hematuria. In which cases, so if like it's an immune complex associated with the chronic infection, but before this would happen, you'll start firstly noting that the kidney function is upset. So checking the blood for the patient, looking for the kidney functions while the patient is taking antibiotics, staying in the hospital should be helpful. Or if the patient have any other symptoms. Anything else that you would like to consider checking while the patient is still in the hospital?
ECG.
Why?
Just to assess the abscess in the septum.
Okay. So basically, to simplify things around, if you're having a patient with infective endocarditis, you need to check for three things. Number one would be the response to the antibiotic therapy, whether the patient is improving regarding his infection, yes or no. So how can I check that? By the clinical picture of the patient, by the inflammatory markers in the blood, and by the blood culture that becomes negative in response to the antibiotic therapy. So this is number one. Number two, you need to look for complications of antibiotics. We've mentioned that we give the antibiotics for up to 6 weeks, and some of the agents are really bad, associated with lots of complications and side effects. If, for example, if giving a patient vancomycin or gentamicin, then there is a high risk of nephrotoxicity. So keeping an eye on the blood levels, keeping an eye on the kidney functions is very important. Flucloxacillin is associated with the steatohepatics picture, maybe jaundice. So as well, looking at the liver, making sure that the patient is all right. So looking for any complications that can happen with a long-term antibiotic therapy. And then the third thing that I need to keep an eye on, the complications of infective endocarditis. So like has just been mentioned about, one of the complications, especially if you're having an aortic valve infective endocarditis, this infection itself can cause an aortic root abscess. So it was just mentioned about doing an ECG to detect for an aortic root abscess. How can you detect the presence of an aortic root abscess on an ECG?
PR interval.
PR interval. So basically what happens is, if you're having an aortic root abscess, the inflammation itself will press on the bundle of His and can cause a prolongation of the PR interval. And this will denote that there's something is going on there at the aortic root, especially if the patient has a normal PR interval on admission. Then this requires a deep investigations, because a transthoracic echo might not be able to pick up an aortic root abscess. And in these cases, more detailed investigations might be required. Is that all right? Any questions so far?
When you're, sorry to go back a bit, when you're querying a diagnosis of infective endocarditis, should you get a transthoracic echocardiogram, or should you go straight to a TOE? Which one's more useful in diagnosis?
You never go for a transthoracic echo right away. So very simply, you start up by doing a transthoracic echo, because basically, number one, in this case, we have the transthoracic echo shows us infective endocarditis. Why would you do a transesophageal echo?
Yeah, sorry, I was just thinking it gave you more detail.
No. It might give you some details, but which details are you looking for? So if you're looking for the infective endocarditis, well, we have found the mass, squirrely infective endocarditis. The patient is feverish. We have a positive blood culture. Definitely, we're going into the right direction. It's infective endocarditis. But would I do a TOE at one point? Yes. Why would I do a TOE? Looking at the valve now, not looking at the infective endocarditis. So the most important about the TOE in this condition, in some patients, while the transthoracic echo might not show evidence of infective endocarditis, we're not sure about the diagnosis, then yes, we go to identify the presence of the lesion of the mass itself. In other cases, when we actually do identify the mass, TOE is not here to diagnose infective endocarditis. but to help us to assess the valve itself, which brings us to the next point. Patients with infective endocarditis, should they have a surgical treatment or not? So this patient had an infected TUE, like we have said, confirming the diagnosis of the mitral valve vegetation, but it as well told me that the patient does have severe mitral regurgitation. So the question would be, shall I consider this patient for surgery or not? And if yes, when should I consider this patient for surgery? Here it is. Any suggestions? Don't worry, guys. Just say yes. Just say no. Just say maybe.
When they are fit enough to go for an operation?
To go for an operation, would you like? When would you like to do it? Right away, or should you like to wait first?
Right away.
I want to wait and see if they respond to treatment first, and if they do, then I wouldn't have an operation if it's not necessary.
Okay, so this is a very reasonable thought. So basically, number one, the rule about the surgery is if you're having an infective endocarditis, you need to ask yourself, does this patient need a surgery or not, like we have mentioned? And number two, can I delay the surgery as much as possible? Patients having infective endocarditis, number one, they're having septicemia, so their body is unwell. Even if they start responding to the antibiotic therapy, they start feeling better, yet they will need some time to recover. So this is speaking about the whole body. Number two, the tissues of the heart, when they are inflamed, they are very frail. So if you try to get the patient to go for surgery, then the likelihood of having, number one, an infection on the newly placed valve, if you do valve replacement, number two, complications post surgery, dehiscence of the valve or any other complications, because basically when you are trying to suture the valve to the tissues are very frail because they are very inflamed. So it becomes very tricky to do the procedure. It's a very risky procedure. So the aim is, does this patient need surgery or not? And can I delay this surgery right away? So when would you think that this patient needs a surgery and it should be done right now? When do you think this is that? When would you consider this decision?
If the valve is not functioning anymore. If
the patient is not functioning, what would happen if you have if the valve is not functioning anymore?
The patient would go into heart failure.
Perfect. Yes. So if the patient developed evidence of heart failure, this is an indication for surgery. Any other indication that you might think of? Any suggestions from anyone?
Aortic root abscess.
Aortic root abscess, perfect. Another complication that might require an urgent surgery. Anything else? What would happen if you're having a patient with aortic root abscess that does not go on the surgery? So the aorta itself might rupture because of the abscess roots in the wall. So you're having a ruptured aorta. Definitely is not a nice scenario. So definitely aortic root abscess. Patient is having developed heart failure. Nothing that will repair the valve. They will go into intractable heart failure and they will die during the hospital admission if they do not have a surgical intervention. What other complications that you might consider that the patient needs surgery right away?
I don't know, but what is about septic emboli?
Septic emboli, perfect. So this is another indication for surgery, and the worst would be cerebral septic emboli. So patients can develop encephalitis secondary to infective endocarditis. They can develop discitis secondary to infective endocarditis. They can develop lung abscess if they have a tricuspid infective endocarditis, or splenic abscess if they have mitral or aortic infective endocarditis. So septic emboli can actually threaten the life of the patient and can lead to a massive stroke to the patient. So this brings us to the next thing is stroke. If the patient develops a stroke, then they're having a high risk. Then again, they need to go to surgery. Any other complications that you might think of? What if the patient does still have fever despite all antibiotics that you have given? So again, failure of antibiotic therapy. So the guidelines, the VSIT guidelines have suggested a few things to tell us when or should we not get the patient to surgery. You're not required to remember them. You're not required to dig into them. It just very simply, they are all revolving about what you have just said right now. If the patient is having an infection that is not responding to antibiotic therapy, an infection that is caused by a resistant organism that we know that it will not respond well to antibiotic therapy, patient who developed heart failure, patient who has developed any other complications of infective endocarditis, including septic emboli or any other like aortic root abscess and so on. Those are indication for surgery. If the patient does not need the surgery, then try to delay the surgery as much as possible. But if you establish the diagnosis, try to get the patient right away, because the more complications the patient might have, the worse that he will be, and the more the risks to the surgery that he will develop. So to summarize, what are the complications of infective endocarditis? Like you have said, congestive heart failure, systemic and pulmonary embolism, mycotic aneurysms, strokes, renal, like it has been just mentioned about glomerulonephritis, renal infarctions, and hematologics like anemia or thrombocytopenic purpura. Is that all right? And this brings us to the end of our case. Our patient had severe mitral regurg, yet the patient didn't develop any heart failure, so he managed to take his antibiotic therapy. He went home after completing his course of antibiotics, recovered well, and then came back for elective mitral valve replacement therapy, and he's doing very well now. Is that all right? Any questions about either part of the lecture?
Just one question.
Yes.
It doesn't. It might not be connected with the lecture, but why do some patients need to go through repeated echo procedure? Isn't the one echo showing the vegetation is not enough?
Sometimes you need to look for the complications, like we have said. If the patient is recovering gracefully, then you might need just another echo just to make sure that things are stable, because one of the complications we mentioned about worsening of the valve condition, the patient might develop heart failure. So checking that the valve itself is not getting any worse. Number two, whether the vegetation is getting bigger, because one of the complications or one of the indications for surgery, if you have really big mass that is very threatening or very fragile, to embolize, and this is another indication for an urgent surgery. So basically, an echocardiogram at this point will be helpful to make sure that things are stable. You'll not be able to do an echo every day. You might be able to do an ECG every day. So if you're having a suspected aortic root abscess, then an ECG daily to look for the PR interval will be very helpful. Is that all right?
Thank you.
So, any other questions at all? Okay. So this brings me to the end of the lecture, and I hope it was beneficial to you guys. I hope it might have just a little bit of revision about infective endocarditis, alongside with some refreshment about how to interpret cardiac murmurs. I would suggest that the next time you listen to the patient, try to write down this algorithm first, if you are happy with it, and try to go through the examination stepwise, like it was mentioned in the algorithm, and see if you can actually be able to identify all the parameters of assessing of the murmurs, and whether you'll be able to reach your diagnosis more confidently, rather than just trying to check only the character of the murmurs. So,
yeah, thank you so much, Dr. Kira. It was a very, very good case on infective endo, and a very good systematic approach onto the murmurs as well. That's been really helpful. Thank you guys all. If you guys have no more questions, I think we'll wrap it up there. Dr. Kira, am I right in saying that we're planning another session with you on heart failure?
yes.
Yeah, so I think we'll aim for that within the next few weeks, maybe, but we'll arrange that with you, and we'll make sure we publicize that on
early December, I guess. So yeah, we'll keep you on the date. Once it's
Yeah,
confirmed.
perfect. Yeah, so once we arrange that, we'll let you all know on all the social media. And we have the ECG session with Dr. Bates